Welcome to our webinar titled ASH 2020 Update for MDS and AML. Thank you for joining us. My name is Lee Clark, patient educator, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the program today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the program. If you are unable to view the webinar online, you can call in to hear the audio portion of the program using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type your question in the small text box window, and when you have finished typing, just hit enter. We'll do our best to get to all questions today. When asking questions, I do ask that you do 2 things to help us manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your personal health care. Today, our specialist is Dr. Courtney DiNardio, a clinical researcher with a specialized focus on prognostication and personalized therapeutics for patients with myeloid malignancies. Her clinical and research focus pertaining to hereditary cancer predisposition syndromes has led to the development of the MD Anderson Hereditary Hematologic Malignancy Clinic, which now provides clinical research-based evaluation of underlying cancer predispositions and hereditary cancer syndromes in leukemia patients. Welcome, Dr. DiNardio. Thank you so much for joining us today.
Thank you very much. It is my privilege to be here, and I am going to take a minute to try to get my screen to open up. Let's see here. You would think I would be better versed at this by now. Let's see. And are you seeing the presentation in presentation mode?
Looks great, Dr. DiNardio.
Perfect. Okay, great. So I am going to focus this talk on AML, on patient selection, new therapies, with a focus on updates based on the most recent annual Society of Hematology update. I don't have very much in terms of updates on MDS, and so I want to make sure those of you who are on the call for MDS specifically are aware of that going in. I'm happy to come back at another time or do that in a separate meeting where we can make sure to give MDS the attention it deserves. And so, speaking about AML, just of course, first my disclosures. I think, one of the most important things is to just appreciate how much things have changed just in a couple of years. So this is a slide that is from 2017, which is not that long ago, and it shows kind of that treatment decisions were really very binary. So we had a decision of, is your patient appropriate for standard intensive chemotherapy? And if they are, it is curative intent. The younger you are, the more likely you are to actually be cured with that approach. And our older patients, unfortunately, along the bottom, you can see expectations in terms of a complete remission rate are really the minority of cases. And we've known for some time, this is for the past, 10 years or so, how important genomics is, the cytogenetic information, the molecular classification. We've known that certain folks, such as those in the green and the gold lines at the top, do particularly well with standard therapies, and then there are other patients with complex genomic changes or p53 mutations, that in the red and the dark blue line at the bottom, that don't do as well with standard therapy. And so we knew that, but it didn't really help us decide treatment recommendations because we really only had 1 or 2 different treatment recommendations to offer. And so that, I think, is what is the most important thing to recognize, is just how quickly the field has changed. And so this is a talk that I put together for ASH, not last year, but the year before, showing, we really have multiple different therapeutic options now. It's not just a binary decision, but there's, 4, 8, 12 different treatment options. And I'll go through some of them, in a bit of detail, hopefully not too overwhelming detail, but just to give kind of people a sense of where things really have changed. And I still have that kind of that separation in terms of, are people getting intensive chemotherapy approaches versus lower intensity chemotherapy approaches. But those patients who are on the red side of the curve, I think it's really important to realize how much has improved with the different combination therapies, particularly including venetoclax combinations, targeted inhibitors with FLT3 mutations, IDH1, IDH2 inhibitors. The outcomes in that group have really improved significantly. So starting with those patients who we are giving kind of intensive chemotherapy approaches. Around the country, I think most institutions still kind of recognize that what we call 7 and 3 as the standard chemotherapy, which means 7 days of cytarabine and 3 days of usually idarubicin or daunorubicin, which are called the anthracyclines, and that's the standard therapy. There is a new approval called gemtuzumab azigomycin, which is actually an old drug made new again. It had initially been approved in 2000, and then it had been withdrawn from the market due to concerns of some liver dysfunction, which is real at high doses. And then it was reapproved at a lower dose, either alone or in combination with that standard intensive chemotherapy 7 and 3 for patients who have leukemias with a CD33 positivity. It's a CD33 monoclonal. And so this is kind of the most important thing to realize when it comes to gemtuzumab azigomycin, which is that CD33 antibody. There are 3 different kind of risk classifications of AML based on your cytogenetic information. There's those patients with favorable risk disease who have an inversion 16 or an 821. Those patients, who get 7 and 3 therapy with the blue lines do pretty well compared to those with intermediate risk disease or adverse risk disease. But the incorporation of gemtuzumab azigomycin makes those patients do even better. And so you can see, my big yellow star showing that, it's really in those patients with favorable risk cytogenetics where you are really seeing that incremental improvement of outcomes with the incorporation of gemtuzumab to standard intensive chemotherapy. And even though patients with adverse risk disease, like complex cytogenetics, chromosome 7, chromosome 5 abnormalities, they can have CD33 expression too, but unfortunately, they just don't seem to derive the same benefit from the incorporation of gemtuzumab. FLT3 mutations are one of the most common mutations we see in AML. They happen in about 1/3 of our patients. About 1/4 will have what's called a FLT3 ITD, and about 10% will have a FLT3 TKD. And these mutations are associated in general with younger patients, often with a more kind of proliferative leukemia, meaning that they often present with an elevated white count and a more kind of rapid progression of their leukemia over the course of days to a week or two. And typically the FLT3 mutation is associated with a higher risk disease. And well, we used to treat patients with FLT3 mutations exactly the same as we did all others. We now know how important it is to include a FLT3 inhibitor to their treatment. And so right now, the approved standard of care here is the incorporation of midostaurin to 7 and 3. But there are several different clinical trials with other 2nd-generation FLT3 inhibitors that are ongoing, and some of them are listed here: Gilteritinib, QUAZAR, crenolanib. And so there are several studies that are trying to see if these second generation FLT3 inhibitors will work as well, if not better, than midostaurin with less toxicity. Oftentimes patients with FLT3 mutations are taken to a stem cell transplant for their best chance of cure. And then we know the importance of a FLT3 inhibitor as maintenance after transplant for these patients. And so I'll go through a little bit of this information. So this is data that was presented by Keith Pratz at ASH, looking at the 38 patients who received 7 and 3 with Gilteritinib in a kind of a safety confirmation study to show that the right dose of 7 and 3 with the right dose of Gilteritinib together is safe to do. And the composite remission rate was over 80%. There were very few, only about 10% of patients did not respond to this therapy. The follow-up time is quite long. We're measured in years, and you can see the kind of that lime green curve showing that patients are doing well and staying well in general on therapy. And then at the bottom is that clinical trial, which is what led to the approval of midostaurin in that blue line, showing that patients who got standard chemotherapy with midostaurin did better than if they received a placebo. And so the question is going to be, in the coming years, does Gilteritinib or other FLT3 inhibitors take that place, and will it do even better? And there are ongoing studies now asking, in a randomized fashion, asking just that. I think one translational aspect to the 7 and 3 Gilteritinib study that Keith presented, which is really important, which I bolded, is the fact that by the start of maintenance therapy, meaning that after patients had finished the induction and consolidation cycles, 85% of them had cleared that FLT3 mutation, meaning that, not just are these patients in a remission, but we're getting a very deep level of remission. And hopefully that is what will correspond and correlate directly with more durable cures, that these remissions will last even longer because we really have gotten rid of the disease. I mentioned post-transplant maintenance. I think the patients with FLT3 mutations are one where we have seen the most evidence of how important it is to include, not just the treatment to get you up to the transplant, but also kind of a well-tolerated oral therapy after transplant to really solidify that remission in that first year or so after transplant, as the graft is really getting in there and starting to work, and just to make sure that nothing happens in that interim. And so the SORMAIN was a clinical trial that was looking at sorafenib, which is another FLT3 inhibitor, as post-transplant maintenance. So patients who were FLT3 mutated who went to transplant were randomized to either getting sorafenib or placebo for up to 2 years after transplant. And in the curve on red along the top are those patients who received sorafenib, and you can see an improvement in relapse-free survival, really confirming that there is an important benefit to continuing on a FLT3 inhibitor in the post-transplant setting. There are some tolerability issues for sure with sorafenib, similar to midostaurin. These are more broad FLT3 inhibitors that inhibit a lot of kinases. You get GI toxicity, in particular, also rashes. And so, again, the hope is that the more kind of potent selective FLT3 inhibitors of the second, third generation ilk will be even more tolerable. And so this is kind of a similar idea of looking at in the post-transplant setting. This is Gilteritinib now, and this is actually part of the clinical trial which led to the approval of Gilteritinib. So patients who had relapsed leukemia received either Gilteritinib or alternate therapy. So these are the patients that were on the Gilteritinib arm who went to transplant, and you were allowed on this trial. It kind of had an allowance to then go back on the Gilteritinib after transplant. And certainly there are a lot of kind of intrinsic biases to a study like this. The patients who were able to resume Gilteritinib after transplant, probably didn't have graft versus host disease and had a nice graft with normal count recovery, et cetera, et cetera. But you can see that these patients do seem to benefit from resuming Gilteritinib post-transplant. So again, additional evidence that this really is an appropriate treatment strategy for patients with FLT3 mutations. IDH1 and IDH2 mutations are also increasingly important in the treatment of AML, not because they have kind of prognostic information in and of themselves, meaning that, whether or not you have an IDH1 or IDH2 mutation doesn't really kind of make you riskier or less riskier in terms of the classification, but they're important because we have targeted therapies for them now. So about 20% of patients with AML will have an IDH1 or an IDH2 mutation. And different from FLT3, which is associated with kind of younger patients, patients with IDH mutations tend to be older. They do really fascinating things inside the body. They're kind of this oncometabolite, but I'm not going to go into that now, but I'm happy to talk offline about that. And so the IDH inhibitors are approved in the relapse setting as single agents. And this is kind of, two different studies that I put on one slide, just because even though they are different drugs and they are inhibiting different mutations, the IDH1 and the IDH2, you actually see pretty similar results. And that's a kind of a composite remission rate of about 30% and overall response rate of about 40% with patients who are able to obtain a remission on these therapy having, a estimated kind of survival on these agents of about just under 2 years. And so they are effective for sure, although not curative in and of themselves for the majority of patients. And so, one of the questions that has been presented recently is, just like you add a FLT3 inhibitor to patients with FLT3 mutations, should you be adding an IDH inhibitor to 7 and 3 intensive chemotherapy for patients with IDH mutations? Obvious question to ask, and this is some of the original phase 1 data that was presented by Eitan Stein, recently published, looking at the outcomes of patients with these mutations with the addition of IDH inhibitors to the standard therapy, and the responses really do look quite favorable. The follow-up is relatively short, and so that's why it's an estimated 12-month overall survival that's provided, but it really does look encouraging, especially when you consider that in the gold colors, about a third of these patients are enrolled with what we call a secondary AML, so an AML coming from like an antecedent myelodysplastic syndrome. They may have been treated with hypomethylating agents before, and so just in general, that is a higher risk population. And so having a clinical trial where there's that many patients with these secondary AML, it makes these numbers look all the more impressive. So there's an ongoing phase 3 study now that's being enrolled in Europe, primarily the HOVON and the German AMLSG group, who are doing a massive randomized study of 7 and 3 with enasidenib versus placebo versus 7 and 3 with ivosidenib versus placebo, and then consolidation therapy, and then maintenance therapy with the IDH inhibitor alone versus placebo, to try to figure out kind of the importance of each and every step along the way, which will be a really impressive feat of a study, which will enroll about 1,000 patients or so. So it'll take a couple of years for these results, but this is ongoing now. CPX-351, which is called Vyxeos, is kind of a similar idea as 7 and 3 in that it has cytarabine and it has daunorubicin, but it's packaged in a different way. So what CPX-351 is it's kind of the perfect chemical combination, a 5-to-1 molar ratio of cytarabine and daunorubicin, which in test tubes is the way, the right combination to affect the most leukemia cell kill. And so they kind of made this molecule as kind of a smarter 7 and 3. And it was evaluated in older patients, but those who were appropriate for intensive chemotherapy in the age range of 60 to 75, who were randomized to either the standard 7 and 3 or CPX-351. And in patients who received CPX-351 in purple along the top, you can see that there is a nice kind of what we call a tail to that curve, meaning that the patients who do well after a year or so seem to continue to do well. And that, is encouraging that there could actually be kind of a cure rate at that point. And so this was follow-up. This is, you can see at the bottom, this was a presentation from Jeff Lancet at ASH in 2016, and there hadn't been kind of additional follow-up data for some time. But Jeff, just at ASH, a couple months ago now, presented additional follow-up. So we now have 5 years post-transplant. And you can see that that purple curve, which is the patients who received CPX 351, you still see that real nice curve separation with patients receiving CPX 351 continuing to do very well. So especially that middle curve, those patients who went to transplant, we're seeing what appears to be a long-term remission of over 50% are alive and well 5 years post-transplant. And so that's a really important number and helps to confirm that CPX 351 really is an effective strategy for these patients. And we don't know the level of what we call measurable residual disease, because that wasn't something that was assessed in this trial, but the presumption of many people, including myself, is that most likely what CPX is doing is providing even deeper remissions, getting to that MRD negativity rate, so that as they're going into transplant, they have less disease, and so transplants are more effective, and patients are benefiting in that way. Venetoclax is an incredibly important new therapy, and it is approved now in combination with lower intensity therapies. But I started my talk, I'm talking about the more intensive combination approaches. And so one study that we've been doing here at MD Anderson that a fellow, Dr. Curtis Lakowitz, presented at ASH is whether the addition of venetoclax to intensive chemotherapy is beneficial. And so this is a clinical trial that has different cohorts enrolling both newly diagnosed and relapsed patients with acute myeloid leukemia getting what's called the FLAG-IDA induction consolidation chemotherapy regimen with the addition of venetoclax. So not randomized, everyone is getting the combination of FLAG-IDA with venetoclax. And it's kind of a busy slide. This table has, the different cohorts of patients who are relapsed or who are newly diagnosed, but kind of in bold, you can see the composite remission rates are in the 70% or higher rate in the relapse setting, which is impressive. Usually relapse patients, you have about a 30 to 40% chance of remission with a standard intensive chemotherapy. So it certainly seems like venetoclax is adding to the effectiveness in the relapse setting. And then you look at that MRD negativity rate. This is defined by flow cytometry. And again, even in the patients who have relapsed leukemia who are getting this combination, you're seeing the majority are being able to obtain an MRD negative remission and able to transition to a transplant. And those patients in the relapse setting who are able to go to a transplant, with that kind of blue curve in the Kaplan-Meier in the bottom seem to do really well and stay in a remission and do well post-transplant. And so this really, my hope is, could be an effective strategy for more patients moving forward. So I've mentioned MRD a couple times, and I think it's important to define. MRD is how we measure residual leukemia. And so the first step we need to do, of course, is to make sure that we don't see leukemia. That's called a complete remission. And so, when the pathologists or when we are looking at the bone marrow report, we're looking at these slides, do we see any leukemia? If we don't, that's called a complete remission. But the leukemia can still be there below the limits of our detection. And so we can assess that in different ways. So about half of patients with acute myeloid leukemia will have chromosome changes, cytogenetic abnormalities, and so we do cytogenetic analysis. So we routinely test about 20 cells, and so the sensitivity of that approach is about 1 in 20. The next kind of deeper level of MRD detection is what we call flow cytometry. This is it is used more and more frequently because it's applicable to most AML patients. You can look in their report and see if the phenotype is different, is consistent with leukemia cells. It does require some interpretation, and so there is a level of expertise that is needed by your pathologist to be able to do flow cytometry. And then RT-PCR is something that is even more sensitive for specific types of leukemia that have what we call fusion transcripts, like the inversion 16 or the 821 or MLL translocations or NPM1 mutations. Certain things we can do a test called a PCR, and that's very sensitive, but it's applicable for that 30 to 40% of AML that have one of those genomic changes that is amenable to PCR. More and more, just that mutation analysis we do, that next generation sequencing, looking for gene mutations can actually be used as MRD technology. It's not particularly sensitive, although it's probably along the lines of flow cytometry. And so I think increasingly over the next year or so, we're going to see NGS as a measure of MRD, which is going to be more and more validated and appropriate to do. So this is an example of what PCR, so the most sensitive way of assessing for patients with NPM1 mutations. And NPM1 mutated leukemias in general tend to be a more favorable leukemia that we frequently do not recommend a transplant in first remission because we often are able to obtain a cure with standard intensive chemotherapy alone. But this just kind of shows how important MRD analysis is, even within kind of a classification subgroup. So these are patients with favorable leukemia, right? And so we think we're going to give them intensive chemotherapy, induction consolidation, and then patients are going to be cured. And so in red, along panel A, you can see that actually about a quarter of patients are going to be MRD positive. And there really is a difference in terms of expectations, in terms of survival, and then on the next slide, in terms of relapse. And so but it's also not one-to-one. It's not like each and every patient who is MRD negative is going to be forever cured. There's still 34% of patients who are MRD negative who do relapse, and some patients who are MRD positive don't. But it provides really important additional information that helps us kind of gauge and modify our treatment program in real time. And so it especially now that we have therapies that are being designed in that MRD positive space and the role of transplant. This is why when you are seeing a leukemia physician, we care a lot about the persistent disease based on MRD. One other reason it's really important is because we know that as you're going to a transplant, the more disease you have, at the time of transplant, the harder it is for that transplant to work, to kind of get in and get rid of all that residual leukemia. And so, there's this one study from back in 2016 that suggests that patients who are MRD positive in that dotted gray line, have outcomes that really reflect patients who are going into transplant with active leukemia, as opposed to patients who are in a very deep remission, MRD negative, and those patients are in the blue dotted line who do much better going into transplant. And so other studies haven't been quite so discrepant as this, but it does provide us that additional information that if we have the ability to kind of use an effective therapy that's going to help make a patient go from an MRD positive to an MRD negative remission, that's really important if we can prior to transplant. And so what are those different therapies that we have? Well, one of the most important new approvals that we have is something called CC486, which is also called oral azacitidine. It's not exactly a one-to-one equivalency, and so the IV azacitidine is not the same as oral azacitidine. It's metabolized a little bit differently, but same idea. And this was the study, it's called the QUAZAR study, that led to the approval of CC486 in patients who had intensive chemotherapy, were in a remission, and were not going to transplant. And so patients were randomized to receive either oral azacitidine or a placebo. And in blue, you can see that these patients who received oral azacitidine had a doubling of their overall survival and their relapse-free survival, and that led to the approval of CC486 for maintenance. And what's important that I've circled at the bottom here is about half of the patients who are on this trial actually were MRD positive when they went on this trial. So they were in a remission, and they weren't going to have any additional therapy. They weren't going to transplant, but they were MRD positive. And then at the time that they were randomized, if they were randomized to oral azacitidine, more patients were able to transition to an MRD negative state. So that's what's kind of highlighted in that bottom bullet on the summary, that just over a third of patients who received oral azacitidine who were MRD positive when they went on the study transitioned to an MRD negative state. And so this is not approved in that manner, but my hope is that we can use this maybe alone or in combination therapy, maybe with venetoclax, for instance, to try to kind of get patients into a kind of a deep MRD negative state to transition them to a transplant that's going to be able to maximally benefit. There was some additional information in the oral azacitidine study that was presented at ASH in December, and Hartmut Donor presented a sub-portion of this study, which allowed the oral azacitidine to be escalated from 14 days to 21 days if their blasts increased a little bit. So this was kind of an interesting and a bit unusual design where patients could start progressing, have a little bit of disease, and then you were able to increase the oral azacitidine to kind of more replicate a more standard azacitidine dose level. And in patients that did that on the oral azacitidine arm, patients were kind of more likely to be able to regain a remission during this portion. And so it kind of further identified that this oral azacitidine really is providing some benefit, even in the setting of a more active leukemia. And so I think we're going to see more and more studies being designed with oral azacitidine as kind of a backbone therapy and as therapy. And I think this is a great thing for our patients, of course, who aren't loving coming back and forth to clinic every month for a week of IV infusion. So as oral azacitidine and oral decitabine become more and more kind of standard and appropriate to use, I think that's going to really be a benefit for our patients. I have just this one slide because there's way too many early kind of phase 1 clinical trials looking at immunotherapy options. But I think this is the right place to be thinking about them, which is in that kind of maintenance setting. So we've given our standard, whatever that appropriate frontline leukemia therapy is, and we have hopefully patients in a remission. And then, this is one of the places I think that immunotherapy could be the most effective, which is where, there's a little bit of residual leukemia, maybe below the limits of our detection. And this is where kind of activating the immune system surveillance, immunity can get in and eradicate any residual leukemia. And so many different clinical trials are ongoing to address kind of these various different immunotherapy options, if there's one or more that are effective in this place. I'll transition now to the older AML patient at diagnosis, a patient who we think is maybe not appropriate or eligible or would be best served with a more kind of standard cytarabine-based chemotherapy approach. And this is an MD Anderson slide looking at patient outcomes over the decades. And on the left, you can see our younger patients, those younger, arbitrarily than the age of 60. And you can see by decade, we really have made incremental improvements. And for patients over the age of 60, we really, have been struggling to see clear benefits. But this stopped in 2009, and this is where kind of the story really, I think, has shown such dramatic changes, and that really highlights around the identification of BCL2 inhibition. And so just a very quick kind of schema to show that venetoclax in that green, it's a small molecule which goes in there and binds and inhibits BCL2, which then causes the release of many other bound proteins that are preventing a cell from cell death. And so there's this kind of normal cell death pathway that cancer cells are trying to prevent from happening, right? They're trying to usurp this pathway. And so leukemia cells that are sensitive to venetoclax are very sensitive. So, that cell will bind and you get this release and initiation of apoptosis. And then the leukemia cells are kind of pushed into that apoptotic cell death pathway that they should have been on long ago. And so this, is one slide showing how kind of important the addition of venetoclax is to azacitidine. In the top, you can see the CR, the complete remission rate, the composite remission rates are really double when you add venetoclax, and that correlates to an improved overall survival in that blue curve along the top. And that really regardless of genomics, even patients with, high risk cytogenetics or FLT3 or P53 mutations, patients are benefiting from the addition of venetoclax. And so this has been a really important, really game-changing therapy for our older patients that otherwise would have just gotten azacitidine alone. Even though responses, though, are clearly better with a combination, really regardless, there are kind of different categories of responses. And so some patients have really long remissions with the combination, and those tend to be patients with NPM1 mutations or IDH mutations. That's shown in the kind of the red curve in that group A group, those patients who are in a remission which lasts well over a year, as opposed to patients who have relatively short-lived remissions. And these patients tend to have more kind of complex genomic changes, P53 mutations, sometimes FLT3 and RAS mutations. And so that as we know more and more about these combinations, we're realizing that there are kind of characteristics of who's going to be able to have a longer remission with this combination than others. IDH mutated patients do very well with venetoclax combinations, with composite remissions shown here in the 60 plus, 80 plus. FLT3 mutated patients do okay, not quite as well as the IDH mutated patients, but in panel A, the combination of azacitidine and venetoclax, definitely you see an improvement compared to azacitidine alone. And I think one of the somewhat surprises, I would say, of the recent kind of ASH meetings was, in the academic world, where oftentimes we were debating between azacitidine and venetoclax or kind of a azacitidine FLT3 inhibitor combination for patients with FLT3 mutated disease. And there was an update by Eunice Wang of what was called the LACE-WING study at ASH, which looked at kind of an ongoing large randomized study, which was looking at Gilteritinib alone, which was that second generation FLT3 inhibitor, versus the combination versus azacitidine alone. And there was a safety cohort that was kind of presented of 15 patients that got the combination, showing that, the combination was well tolerated. Composite remission rates were in the 67% range, kind of in line with what we would expect. But then there was this kind of somewhat surprising post-ASH press release that the study had failed to meet its primary endpoint, and we haven't seen the data specifically yet. So we don't know kind of the specifics of this, but I would say, at the current point in time, the azacitidine and venetoclax really does seem to be kind of more and more the approved frontline go-to therapy for patients with FLT3 mutated disease. Patients with P53 mutations are one of the kind of the challenges that we are still facing. And so this is a MD Anderson specific clinical trial that was looking at 10 days of decitabine with venetoclax. And there has been some kind of preclinical evidence that 10 days of decitabine for patients with P53 mutations may be particularly beneficial. And so we enriched the study to enroll patients with P53 mutations. You can see about 35 of them were P53 mutated. Unfortunately, even though patients respond well, a composite overall response rate of like 2/3 of patients, 66%, with P53 mutations, where it's not translating into really durable survival. And so as much as I wish venetoclax combinations was the kind of effective thing here, there's definitely more to be discovered and still a open need for improved therapies for patients with P53 mutations. Certainly patients can benefit from transplant even after venetoclax-based combinations. This is somewhat of a self-intuitive slide, but just to kind of reaffirm that, we used to think that transplant, the way to get to a transplant was with intensive chemotherapy, because those were, the patients that went into deep remissions. But now that we have venetoclax combinations, many of our patients go into very nice remissions with venetoclax combinations also. So this is just an analysis of those patients who were on venetoclax-based combinations and went to a transplant. About 10% of the patients on the original studies went to a transplant, and they did really well. So it highlights the fact that if you have a patient who has one of those genomic phenotypes that is more likely to have a short-lived remission on venetoclax combinations, that, you know, consider a transition to a transplant, and that may be the most effective treatment for that patient. I mentioned that, you know, there's definitely a need for improved treatments for patients with P53 mutations. One of them that I hope will continue to show promising results is something called magrolimab, which is a CD47 monoclonal antibody. So it's actually an immunotherapy, a checkpoint, a macrophage checkpoint inhibitor, which was evaluated in MDS and AML patients. And preliminarily, there were several P53 responses. And so the study, you know, became enriched for patients with P53 mutations. You can see in this kind of table, about 73% of the patients that were enrolled actually had P53 mutations because of that early signal that this may be effective for them. And so, you know, in about 30 patients with P53 mutations, the overall response rate, again, in that kind of top 69% range, with short follow-up thus far. So we definitely need to wait and see where the data goes, but I'm certainly hoping that this could be an effective treatment strategy, maybe in this azacitidine magrolimab doublet or with the incorporation of venetoclax or other therapies. And so this is one that I've definitely been watching and excited about. We don't use a lot of LDAC, low-dose Ara-C, low-dose cytarabine combinations in the United States, but we have a few approved regimens, and so it's, I think, important just to bring them up for completeness. The VIALE-C study was looking at venetoclax in combination with low-dose cytarabine as opposed to in combination with azacitidine. And low-dose cytarabine tends to be the kind of the backbone AML therapy for patients with AML in various different parts of the world, like Australia and the UK, for instance. And so this was a study looking at kind of the fact that when you add venetoclax to low-dose cytarabine, you can see kind of a doubling of the median overall survival, a more than, doubling improvement of the overall response rate, improvements in transfusion independence, improved quality of life on different patient-reported outcomes assessments. And so again, if low-dose cytarabine is, your treatment backbone of choice, then the incorporation of venetoclax really helps in this point, in this fashion too. There is also another FDA-approved regimen, which is called low-dose cytarabine with Glastigib, which is a hedgehog signaling pathway inhibitor. And it has been a bit overshadowed, I think, by venetoclax. This combination was approved really, at the same time that low-dose cytarabine and venetoclax was. But when you look at the response rates and the overall survival, it really is very similar, low-dose cytarabine and Glastigib to low-dose cytarabine and venetoclax, even though there's always challenges with cross-trial comparisons. And so I think this is definitely something to kind of keep in mind, especially patients with secondary AML who have, who've received a prior azacitidine or decitabine. This could be an effective regimen, and so something to kind of keep in the back of your mind for treatment options. And then in the last few minutes, just to speak briefly on relapsed AML. We've gone through different treatment algorithms in the frontline setting. I think one of the most important things to remember, which I talk about a lot, is the fact that the leukemia that you have at diagnosis isn't necessarily the same kind of leukemia characteristics that you have at relapse. There is changes to the actual disease based on selective pressure of different chemotherapies and treatments. And so, this is showing you one example that can, relapse in any number of different ways. And so it's really important to repeat that assessment in patients in remission or in patients at relapse to make sure that you are aware of any potentially targeted treatments and that you are optimizing the therapy for your patient at that time in their treatment. There are kind of different classes of therapy in the relapse setting, and I think the most important thing to do is, as I said, do that genomic assessment, see if they have a FLT3 mutation, an IDH1 and IDH2 mutation, because there are specific targeted therapies that are oral, well-tolerated, that are really appropriate in that setting. Is there a role for gemtuzumab zigamycin? And then, you know, the kind of more less aggressive versus more intensive chemotherapy approaches. And kind of along those lines is the goal to kind of get them into remission and then go to a transplant in the relapse setting where kind of a more aggressive approach may make sense. Gilteritinib is, we've talked a bit about, this is that second generation FLT3 inhibitor, and it is approved in the relapse setting based on this study, which showed that a daily pill that you take was more effective than standard chemotherapy options. The rates of composite remissions and overall response was higher. The percentage of patients able to transition to a transplant was higher. Overall survival was higher. And so this, you know, certainly in a patient with a FLT3 mutation, you really want to consider a gilteritinib containing regimen for patients at relapse. There was a study at ASH by Dr. Dover, which shows that in addition to gilteritinib alone, the combination of venetoclax and gilteritinib can be really effective. In purple, you know, over 50% of patients are achieving a leukemia-free state, and so their counts aren't totally recovering. This is a very potent combination, even though they're both oral, well-tolerated therapies. You put them together, and it is very what we call myeloablative. It really drops the counts, but it can be very effective at clearing leukemia in the relapse setting. And so this is an ongoing clinical trial looking at the kind of combination of these two oral therapies for patients with relapse FLT3 mutated disease. Just to highlight the role of the IDH inhibitors, I had shown this slide at the very beginning, but to show this is where these drugs are approved as a single agent in the relapse setting. And they can be very effective in patients who can respond very well. And then there was another study that I want to highlight presented at ASH of what's called menin inhibition. And so patients with MLL rearrangements, or what are now called KMT2A rearranged disease, it happens in a minority of cases, but actually they're fairly frequent in childhood AML. And these patients oftentimes have very resistant disease. And so there are now a handful, 2 or 3 different menin inhibitors that are in various stages of early investigation. The one from Kura Oncology, KO539, was presented at ASH, showing that several patients are having nice early responses in the original phase 1 dose escalation study, which to me is yet another, exciting avenue where, it's a small subset of leukemia, so just like a small little piece of that pie, but for these patients potentially having effective treatment options for them. And so I think with that, I will close right on the 45-minute hour so we can open for a handful of questions. And so thank you so much. Let me end this and we'll go back to the main screen. Perfect. Now, I don't know, is there anyone that's going to moderate this, or shall I just kind of go and through the Q&As?
Thank you so much, Dr. DiNardo, for that wonderful presentation. Our first question comes from a patient who's wondering about the state of research for patients with secondary AML after 2 MDS. The patient is on azacitidine, but their physician is now recommending the addition of venetoclax to bridge and then possibly going to transplant. What are your thoughts on that?
So patients who have AML that is developing from MDS is one of the more challenging patient populations that we treat, especially if that patient has already received azacitidine or decitabine for their MDS, because that it doesn't usually make sense to kind of give more azacitidine for their new diagnosis of AML when they just progressed on that in the MDS setting. The utility of venetoclax in this space has definitely, I've seen it, and so as we're currently in the era of anecdotes for this, and so I can only speak based on a handful of cases that I have treated in my clinic, but in patients with kind of a higher risk AML who transition, or a higher risk MDS who transition to AML, sometimes the simple addition of venetoclax is able to kind of get that blast percentage back down and able to transition to a transplant. And so it is definitely an option, whether that's the best option compared to a transition to like a low-dose cytarabine combination approach. We don't know the answer to that question yet. Those are trials that are ongoing, but I think adding venetoclax is an appropriate treatment strategy for a challenging case like this.
Thank you so much. Sorry, Lee's having a little trouble with her mic, so you get Julie. We do have a question from someone who's wondering if they're living in Canada and venetoclax is not yet approved for the patient. What are the options in your opinion, Doctor?
These are questions that are really hard. I get emails from folks all over the world on a daily, weekly basis saying, I live in XYZ and I don't have access to this. I think venetoclax is becoming approved in more and more countries based on that VLEA study that shows kind of in a randomized fashion that the combination is more effective. And so I think, it is only a short matter of time, but for the authorities in the various different kind of parts of the world approve it. But every place has different timelines. And so I don't know how easy or challenging it is for kind of expanded access or patient support opportunities to obtain venetoclax if you have a patient with a newly diagnosed AML who would be appropriate for that combination. So there are clinical trials though that are open in Canada, and so one way to participate in a venetoclax containing trial might be an option.
Thank you so much, Dr. DiNardo. Do you see if oral Vidaza is in the future for MDS patients?
So oral decitabine is already, the future is here for MDS patients. And so that one was just recently approved, and the oral decitabine is far easier to kind of wrap your mind around because it's just a 1-to-1 dose equivalency. So the same IV decitabine dose is the same as the oral decitabine. And so that reality is already here. Oral azacitidine, there are ongoing studies now in MDS to try to confirm kind of effectiveness, try to confirm the right, what we call PKs, right? That we understand how much of the oral azacitidine is being metabolized. And so, yes, I think oral azacitidine certainly will have a role in MDS, but it's currently still investigational.
Thank you so much, Dr. DiNardo. Our next question comes from patients who are curious to know, are the outcomes for haploidentical transplants in AML somewhat comparable in outcomes for better matched donors? We know you're not a transplanter primarily, but are patients who are often wondering about outcomes in AML transplant?
It's a great question because I remember learning when I was going through my oncology training, right, that, unrelated donors were optimal. And if you didn't have a fully matched, sibling or unrelated donor, then outcomes with transplant were less optimal. And so, but that has changed, right? So we now have haplo transplants, we have cord transplants, and so almost everyone has a potential donor now. And again, I'm not a transplanter, but you're absolutely right. My understanding from my daily interactions with my transplant colleagues is that haplotransplants really are as effective as unrelated donor transplants. And, you know, the different kind of conditioning regimens that we use to kind of mitigate the risk of graft versus host disease are becoming more and more effective. And so that's what's particularly important with like haplotransplants, for instance, is that we have those effective conditioning and GVHD preventative approaches that are really quite effective. And so the responses are great.
Thank you so much, Dr. DiNardo. We have answered all the questions that were submitted, so I want to take this opportunity to thank you and everyone for participating tonight. Thank you for your time and your expertise. For those of you who might want to watch this again or share it, this will be available on our website in the next couple of days. You'll get an email letting you know that the recording is live and ready for viewing. Again, we want to thank everyone for participating today and for making AAMDSIF your resource of choice for bone marrow failure disease. Thanks again to Dr. DiNardo, to all of our sponsors, and to all of our patients, families, and caregivers for being part of the AAMDSIF family. Thank you so much, everyone. Have a nice evening. Bye.